Good afternoon. I'm Vetta Sanders-Thompson. I'm on faculty at the Brown School at Washington University in St. Louis, and I've been asked to speak with you today about the equitable distribution of vaccines. My work is in social justice and health equity, particularly as it affects marginalized communities, and I'm going to share with you some of the learnings of my work. First, I want to thank the Missouri Immunization Coalition for inviting me to speak. Um, I'm going to, in order to accomplish my goal effectively, I'm going to discuss the collection of the challenges and the construction of solutions associated with increasing vaccination rates. I'm going to discuss barriers that promote, that detract us from the equitable distribution of vaccines, but I'm also going to discuss solutions. And I'm going to help you think about strategies that we can use to address the issues among diverse communities as it relates to vaccination. Immunization has played a significant role in preventing virus-related morbidity and mortality. But despite this progress in this area of medicine and public health, thousands of adults die each year of vaccine-preventable diseases. Consider that, an estimate from 2016 suggested that 70,000 adults would die from vaccine preventable diseases, compared to 200 childhood deaths. That statistic is the reason that this afternoon I'm going to focus on adult vaccination, but many of the comments that I will make apply to childhood vaccination as well. The distinction is that we currently have some infrastructure to support child vaccination that we absolutely lack for adult vaccination. And although our child vaccination infrastructure is not ideal, it does not solve all of our issues. It is much stronger and it provides the leverage we need to save lives. In addition, as a part of that infrastructure, we have developed mechanisms to assure that people are not deterred from vaccination due to cost, one of the barriers that we know many marginalized communities will face. We don't necessarily have that assurance of that infrastructure, again, for adult vaccines. Now, I'm discussing equity. And when you're discussing equity, it's very apparent that you need to provide a definition so that everyone is on the same page. When I discuss equity, I am not talking about equality. Equality means we give everyone the same thing. That's not what we mean by equity. Equity is the assurance that all members of society have the opportunity for health, a sense of well-being, and the ability to live a full, productive life. Now, we want that for everyone, regardless of their socioeconomic status, their race, ethnicity, gender, sexual orientation, geography, and any other social factor that might contribute to inequity. We observe inequities in a number of spaces. What I am talking about as I discuss equitable distribution of vaccines is health equity. If we gave everyone the exact same thing, we would not take into account those who do encounter barriers based on cost, or those who encounter barriers because in their locale there is not the infrastructure, there are not the providers, they don't have access to the same education that might promote greater health literacy, and so the knowledge base that they're working with to make good decisions about vaccination are not present. Now, there are many factors that affect vaccination rates, and today I'm discussing those factors that are related to equity in vaccine distribution. I'm going to begin by discussing factors related to equity and describing these factors, particularly how they create inequitable systems. I will return to the discussion of what we know about disparities in vaccination and the systemic factors that contribute to these. And then I'm going to end my discussion with solutions to address these factors. Now, as you see on the slide, inequities are produced by systemic issues. In most instances, these systemic issues affect populations to create conditions that lead to differences in exposures and risk and access. And in vaccines, equitable access is important. But these issues are related to what we call the social determinants of health. So when I'm discussing inequity, I'm going to use the World Health Organization definition. And so you see on this slide, it really states that the social determinants are the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at the global, the national, and the local level. And so in this instance, I'm discussing what we see in Missouri, what we see in local jurisdictions in Missouri, but much of this applies more broadly. The next slide is the World Health Organization model that takes us through and helps us to understand the factors that produce these systemic issues. And so you'll see that it talks about structural determinants and then it talks about the intermediary determinants. A lot of what we discuss in our everyday efforts to address healthcare disparities has focused on those intermediary determinants, the exposures, the vulnerabilities, the activities of the health system. But the World Health Organization model and the focus on social determinants ask us to go beyond this, to think about the structural determinants. These include things like the political context in which we make decisions about resources and the distribution of resources for health, as well as education, transportation needs, and any other factors that will act on or affect the way people can access the resources they need for healthy lives, including vaccines. It speaks to governance. It speaks to our macroeconomic policies, because our macroeconomic policies they influence how people earn their living, what wages and income they earn, what disposable income they may have available to take care of healthcare issues, particularly if they lack a strong health insurance plan or they are uninsured. Social policies that affect whether or not providers accept or have to accept certain types of insurance, the extent to which we address the healthcare needs or a variety of other needs that affect the ability of people to live healthily. Education becomes one of the sectors we would be concerned with, because education affects whether people have the information they need to make good decisions about whether to be vaccinated, when to vaccinate, whether to vaccinate their children. Do they understand vaccines? Do they understand viruses? Do they understand and can they distinguish between how we might intervene with, say, viruses as opposed to what we traditionally do and the way people think about bacterial infections? Can they make those, do they understand those issues and can they make those decisions? Public policies affecting health, education, and social protection are particularly relevant. Social policies affecting labor, housing, land, all of these things interconnect to determine who has resources, who has power, who is positioned to act to support their own best interests as it relates to health and well-being, and who is not. And then we also have cultural and societal values. And we've seen the cultural and societal values play out in the context of COVID-19. You know, what you believe about independence and who should direct the decisions made and how we behave and respond to situations, the way we as a society and as communities behave, react, respond to protect the general health and well-being and the greater good. And since I've already mentioned COVID-19, it's been instructive to us. We have learned a great deal and from the way the virus emerged, who it impacted, our ability to protect various communities, to respond quickly to the needs of various communities. Um, and it's taught us a lot about our public health infrastructure and our information systems and how they affect our ability to equitably distribute the resources that are necessary for various communities. And so this slide, you know, discusses some of the things we've learned. So what is collected, what data are collected, what information is collected affects what we know, and it's been important. CDC reports demographic data, demographic characteristics for COVID-19 vaccination. But for race and ethnicity, they've only been able to do this well in terms of vaccination for about 55% of those who have received at least one dose of the vaccine. So, you know, if we've only got the data on race and ethnicity for about 55% of those who received a dose of vaccine, we really don't know, and we aren't in a position to make the best decisions about equitable distribution, particularly when we need to examine, well, for any given population, what were the case rates? For any given population, what was the mortality rate? And then we have to think about and what's their percent of the general population to make a good decision about equity. Interestingly, in this sphere, only 47%, 47 states and Washington, D.C. report race and ethnicity data, and there are differences in how they report that data. And so the comparisons and the discussions that we can have nationally are affected by that. But even within states, the data that they're using means they're having different discussions than maybe the state next door. And so we know that in terms of large scale planning on the federal level, we have some gaps. Interestingly enough, right now, the CDC is not currently reporting data by state. That's a capacity to analyze, to appropriately clean, scrub the data, analyze those data. But the availability of data in real time has implications for how we make decisions about the equitable distribution of vaccines. Now, COVID-19 is a particular case because we are operating in an unusual circumstance. But if we think about it, it's also speaking to our ability to know and understand where we are in vaccine distribution for any of the other adult diseases or childhood diseases where we have the capacity to prevent disease. And our data lag compromises our ability to make equitable decisions in real time. You know, when you go to the CDC data, and I was in 2021, the data were covering through 2018. So we're in 2021 and we're relying on 2018 data. That's a real lag. And so we need to think about that. We also have limited samples. And that will affect what we understand about the needs of some groups, particularly very small groups such as American Indian and Alaska Native. And many communities are then left feeling as if they are being left out and excluded. That feeling of being left out and excluded leads to people having less trust in the requests made by governmental agencies, the action of governmental agencies. And in some ways, we're doing this to protect privacy and to make sure we're not making errors, but we're not explaining to people well enough so that they understand and they don't lose that sense of how important they still are to us in a societal situation. And it makes it difficult to identify the contextual factors that are important for the planning that we need to do. And with respect to COVID-19, what we do know is that Black and Hispanic people have received smaller shares of vaccinations compared to their shares of cases and compared to their shares of the total population in most states. The share of vaccines received by Black people also continues to be smaller than their share of deaths in most states. The share of vaccines received by those we classify as Hispanic, and I say that because how we classify people, the terminology we use is relevant to how they feel about the data and their representation in the data, but I'm not going to dwell on that point here. But those who are designated as Hispanic seem to have a similar to higher than their share of deaths in most reporting states, although in some states it continues to be lower, and the share of vaccines received seems to be related to the deaths, although maybe not their percentage of the population. For example, in Colorado, 10% of the vaccinations have gone to Hispanic people, while they accounted for 41% of cases, 25% of deaths, and they are 22% of the population in that state. And so you can see that's one state that's an exception. Other states, the opposite will be true. Similarly, in the District of Columbia, Black people have received 31% of vaccinations, while they make up 55% of cases and 70% of deaths and 46% of the total population. The size of these differences vary across states, and the number of states where the shares of vaccination received by Black and Hispanic people are more proportionate to their shares of the total population and or their shares of cases or deaths in the state. These numbers are growing. So we have reason for optimism. But the question is often asked, how do we get to a point where these numbers have to grow and even out as opposed to communities are served equitably from the beginning? Because what we have to remember is when these numbers have to grow and communities are not served equitably from the beginning, and they can discern that based on their ability to access what they perceive others to be accessing more readily, again, affects trust, affects willingness to receive the messages, adhere to messages, and respond positively to messages from those entities charged with overseeing health and well-being. And so if we want to assure greater trust, we have to make sure that we are meeting needs, we are responding appropriately from the beginning. Lack of data hinders our ability to do that. These smaller, there are areas where there have been smaller differences observed in so the distinctions between vaccination, case, mortality, and share of population. The CDC issues reports, and you are able to access those reports. My slides provide a link to the source of the data that I am using. Those data come from the Kaiser Family Foundation, because as I said, the CDC has not been analyzing and releasing data by state. And so that has meant that organizations outside of our general health and public health structure have stepped up to the plate to do some of these analyses for us. But it's a clear indication, to the extent that we're using these data, that we really need a public health infrastructure that can move almost seamlessly to this level of analysis when necessary. Now, I did pull, because this is Missouri, I pulled the Missouri data for COVID-19 based on the Kaiser Family Foundation analysis of state data. And where African Americans and Blacks are concerned, 8% of vaccinations as of March, mid-March, had gone to African Americans, 25% of cases. But where they were 25% of cases and 12% of deaths and are 11% of the population. So we know that if we base the decision on cases, there's an under vaccination, and that would speak to whether or not sufficient resources were deployed to this community early enough. But if we're looking at deaths, there's a difference, but it's smaller. And if we're looking at percent of population, there's still a difference, but it's still smaller. With the Hispanic population, 5% of the vaccinations, 13% of cases, 2% of deaths, 4% of populations. So again, it's what metric do you want to use? And given those differences between the African American population and the Hispanic population, you can see where the decisions about equitable distribution of vaccines become difficult and require that we have access to as much data as possible. Because using these numbers, we have the decision to make. Are we concerned about the cases? Or are we concerned about mortality? Because those are two different strategies for how we would go about equitably distributing vaccine. And we're just talking race ethnicity right now. There are many other areas, as I talk about vaccines in general, that we have to think about. For Asian Americans, they received 3% of vaccinations based on the Kaiser data. They were 2% of cases, 1% of deaths, and 2% are 2% of the population by their estimates. And so you could say this is a case where there's a racial ethnic minority group that has done well. Among white individuals in Missouri, they've received 83% of vaccinations. They were 54% of cases, but they were 83% of deaths, and they are 82% of the population. So again, looking at what goes on with the population, looking at the metric, what decision really allows us to see the complexity of the decision making that has to take place when we're thinking about equitable distribution. And just again, I want to reiterate that states are improving their data collection and their reporting, and that's going to permit better planning. And hopefully, as we improve the data collection, that includes improvement in the quality, not only in the quality of the data, but the type of data that are collected so that we can make decisions. Because again, one variable might be what are the comorbidities in the various communities that we're looking at. Because in the case of COVID-19, those comorbidities have implications for who is more susceptible to the virus, and therefore who we might want to move to protect. Similar to the position that we've taken around age, because age affected susceptibility. And some people might argue because age affected susceptibility, the portions of our population with larger percentage of individuals in the age group that was more vulnerable should receive more attention. These are issues that we will confront and that we have to make decisions on as a community. In the next slide, I'm going to talk about disparities in adult vaccination generally. And vaccination coverage generally is lower among adults than it is among children for the vaccinations that we recommend in order to promote health and well-being. But we know that the vaccination rates are lower, particularly when people are without health insurance. Um, Compared to those with health insurance. And adult coverage differs by the type of health insurance that a person has. Um, and by that, we mean public versus private insurance, with private insurance resulting in higher rates of vaccination than public, except for in the case of influenza and pneumococcal vaccination. Adults with a usual place for health care are more likely to report vaccinations than those without a usual place of care. And here, health insurance doesn't affect that fact that people who have a place where they go for routine care are more likely to be vaccinated. Now, we understand that that's because they likely establish a relationship with a provider. That provider knows their history, knows their risk. That provider is probably more comfortable recommending vaccines and having a conversation with the person if that person is perhaps hesitant to be vaccinated. That's less likely to occur if a person is moving from provider to provider because of their health insurance, their ability to pay, and so no relationship has formed. Vaccination among US born adults is significantly higher than vaccination among foreign born adults. And that includes something like influenza vaccination. And there are large gaps in pneumonia and tetanus vaccination in this category. And we know that recent immigrants are less likely to receive recommended vaccinations. And so the question becomes, given the vulnerability to these viral infections that we know would reside in these communities, do we make extra effort? How do we distribute resources to make sure that we are reaching out to, contacting these communities? Because at the end of the day, this affects the overall health and well-being, the opportunity for infectious spread in all communities. Some of the factors that would affect foreign-born adults, particularly recent immigrants, has to do with their status, has to do with language barriers and communication barriers, and the extent to which our public health and health systems are prepared to cope with those differences in language, um, those differences in culture and cultural norms and societal values and norms that they might encounter, and some mistrust that may exist related to how the healthcare system responds to individuals in those communities who are not documented. Um, we know that health insurance coverage, although beneficial in improving access to health care services, might not be sufficient in and of itself to achieve optimal adult vaccination. Um, Even among people who have health insurance and have a number of contacts with their physicians during a particular year, we know that over 50 to 60% of them will report not receiving one or more of the recommended vaccines. We also know that here provider attitudes about adult vaccination, practice patterns in provider offices, um, some of whom don't routinely incorporate assessments for vaccines for adults into their practices, and other barriers to vaccination might determine whether patients are offered and receive vaccines. This points to a systems issue, particularly in the communities that are most vulnerable. To what extent do providers have the resources that they need To what extent do they receive reimbursements that would incentivize them to access the resources they need, motivate them to have these conversations, to assess, follow up, make recommendations, and be positioned to provide or to refer to providers that would be accessible to the populations that we already know are more at risk of not having adequate access to vaccination resources. Um, we know that individuals who have greater than one physician contact during a preceding year are more likely to have coverage of recommended vaccinations. But we know Black, Hispanic, and Asian adults tend to have lower vaccination coverage than whites for all vaccines routinely recommended for adults. So in that respect, what I was describing for COVID-19 is not that different than what we're seeing with other adult vaccinations. There are differences for influenza, Tdap, hepatitis B vaccination. Interestingly enough, we see this disparity that we see in the general population. Studies have examined vaccination rates among healthcare providers, and we see a similar pattern with white healthcare providers generally having higher vaccination coverage compared to Black and Hispanic health care providers. And so that leads to another systemic issue. To what extent are we working with providers as a system to help them to examine their own preferences, attitudes, how that may affect the communities that they serve, help to address any concerns that they may have so that the patients in that community who respect their providers, who rely on them for good advice, are receiving the best information, the most up-to-date information about not just the vaccines, but resources to pay for them, to overcome any barriers to those vaccinations from the people that they trust and look to for that information. Now, adult vaccination coverage has remained similar to over the last few years, with only modest increases being observed in the rates of vaccination. One of the vaccines where we've seen improvements has been HPV vaccination among males 19 to 26. We've also seen improvements in HPV vaccination for Hispanic females in that same age group. But provider attitudes can affect where and how vaccines are distributed. You know, many people don't think about some of the other places that they can receive vaccines. They're really thinking about their physician or their provider. And if that provider is not stressing the role of vaccination, um, being up to date and recommended adult vaccinations to health and well-being, this will not be on the radar, and it might not be a priority in families and in homes where this can be important. And without assessments of vaccine practices and patterns of recommendation, provider attitudes and biases may impact distribution in ways that we don't understand. And these attitudes can have regional and cultural patterns attached to them, particularly in areas that only have a few providers. And the prevailing attitude is that they do not see adult vaccination recommendations as a priority to their practice. Now, just a few last slide commenting on disparities in adult vaccination. These disparities can also be based on socioeconomic status, but this can be influenced by how socioeconomic status is being measured, and so it's important to know when we talk about this, how are we defining poverty level? How are we defining the ability to be enrolled in programs that would assure that people could have coverage for vaccinations? Um, all of these things matter. So, but we do know there is a relationship to socioeconomic status, but that also relates to who is insured, who's uninsured, the type of insurance that people are likely to have, and we know that that's also related to vaccination. Um, and studies have noted urban-rural differences in vaccination in some instances. And so this is an area that we have to think about too, the equitable distribution, when we're thinking about the equitable distribution of vaccines. Now, um, in the generally recommended adult vaccination um, types, this is not the same situation that we run into with COVID, where there were strong and there do appear to be strong cultural and social attitudes that affect the willingness to accept the vaccine. These may play out in differently in urban rural areas with some recommended adult vaccines, but there's not evidence in the literature at this point to suggest that these play out as strongly as they have played out for COVID-19. And that's because COVID-19 has become one of the more politicized vaccines that I can think of. Others may have different perspectives, but it has become a politicized vaccine, and that's made for a different, I think, attitude um, in urban and rural areas, although you have pockets of hesitancy and concern and caution even in urban areas, and you have pockets of acceptance in rural areas as well. Studies often tie rural disparities to socioeconomic status, but you also have to think about in rural areas provider availability, the number of providers, the number of providers for whom the ability to distribute vaccines is economically feasible in their practice, related to reimbursement rates, incentives for them participating in programs to promote vaccination. And my final point in this area is that racial and ethnic disparities exist in rural areas just as they do in urban areas. When we talk about rural areas in this space, we often assume a white only environment, but there are racial and ethnic minorities in rural areas. And what we know is that when we examine disparities among racial and ethnic minorities in rural areas, just as in urban areas, they are generally faring worse and are less likely to receive the vaccinations, the health care that we believe is important to health and well-being. And so now I'm going to talk about the equitable distribution of vaccines. And my point here is equitable distribution of vaccines requires equitable access to societal resources. And if you haven't picked that up from the World Health Organization slide that I shared with you and the conversation that I've been having with you so far, I want to state that explicitly. This is about equitable access to societal resources. And so as we think about this, there are a few steps. We have to think about populations that we know from prior data and research are likely to be disproportionately affected by any disease, illness, viral exposure for which we have a vaccine. We need to understand for each of these populations what's their historical access to the resources that are needed in order to receive vaccination at the same rates or at as needed higher rates as others to mitigate differences in exposures. We need to be clear on what metrics we're using to make those decisions, and we need a rationale for why we are making the decisions we're making that we can share with the public, that don't generate or support additional mistrust and inability to accept decisions that may be in the community's best interest. And we need to understand how our infrastructure is prepared to support or not support those communities, given the strategy we've decided on to make decisions about the distribution, in addition to the populations we know that are most vulnerable. Identifying a population as vulnerable and saying we should do more to make sure that they're not experiencing greater risk of disease because they are lagging in vaccination does us no good if we're not analyzing our infrastructure and resources for delivery and committing the resources and making the decisions to assure that we can respond to the needs of these communities as well as we do the general population. Factors that come up frequently in these discussions are cost, because we've talked about the link between socioeconomic status and health insurance, and the fact that we know that individuals who lag in these areas are less likely to be vaccinated. So we have to think about how we manage those issues. We've talked about access to providers. Transportation becomes one of those factors that affects access. The other issue that affects access is where providers are located. And we know that we have a maldistribution of providers in rural areas where we have many healthcare shortage environments, but also in urban areas, particularly poor racial and ethnic areas in urban centers. And so these are things we have to think about. And if people are to access the providers that are available, transportation becomes a major factor that effectively results in the denial of access to healthcare, and in this instance, vaccines. Now, and now I want to move to strategies to achieve equity. And I think this is what I was really asked to speak to. One of the things that would help, but these are general recommendations, and I think we would talk about these whether we were talking about equity or not. And that's consistent implementation of the standards for immunization practice, not just by general practitioners or family medicine doctors who we know do a much better job of assuring that they make recommendations for vaccination than do medical specialty providers. But we know that in many of the populations where we see disparities in vaccination rates, they have comorbid conditions that lead to specialty providers taking the lead on their care. And if these specialty providers are not incentivized, motivated to, or as aware of the need to adhere to these standards as family practice or general practice physicians are, then those who are in many ways most vulnerable to the viral infections that recommended vaccines can protect against aren't as likely to receive the recommendations that would get them up to date on those vaccinations. We need to enhance provider access to the immunization systems that can help them improve vaccination coverage, because those systems can provide consolidated immunization histories for use by a vaccination provider, and they can help them to determine what vaccinations are appropriate for that patient, that client. And we need to make sure that providers are positioned so that they can use the EMR system that provides the history and data so that they know which patients need what. But we also know that from history and data that using these strategies will not eliminate disparities. Research has suggested that this will move the needle for the general population, but it will not eliminate disparities. And what we probably are looking at is the need for more creative innovative solutions that help us to make use of the data that we have so that we can make good decision making. Now, the next thing that I talk about has to do with the fact that geographic access to services is not an urban rural issue. When it comes to equitable distribution of healthcare in general, but in this case, vaccines, this is not an either or issue. This is a factor that affects both. Um, Geographic access is similar, but we're going to see different solutions in these spaces. We know low income and racial and ethnic and immigrant communities are all affected by geographic access, but their needs are going to be different, and so we have to come up with different solutions. COVID has taught us that infrastructure is a must, and it can't wait until our time of greatest need, and it can't wait till a crisis. Patient education by apps, by physicians, have increased vaccination among racial and ethnic minorities. Um, Racial and ethnic minority women who are pregnant. We know that when we go that extra step, when we use creative and innovative strategies, we can overcome vaccine hesitancy and we can get improvements. Um, but what we have to understand is that it can't just stop with education. Education is usually a individual patient strategy to address what is a systemic issue. There are other creative solutions that we can use to our benefit. Things like mobile vaccination vans that operate based on the best available data in EMR and IIS systems to tell us where are the people who are not vaccinated but who are at great risk, and it would be important to increase vaccination rates. Thinking about how do we use our schools, our churches, our libraries to reach people who are vulnerable to infectious diseases for which we have vaccinations, and this being a strategy to allow them to have easy access to overcome those transportation barriers that might be affecting them. Increased use of pharmacies. There are probably more pharmacies available than there are physicians' offices, practices, clinics. Now, this may not be the best solution, say, in a rural area. It may be more workable in certain urban and suburban areas. But we've got to be creative and think about what works in what specific area. Community health nurses. Perhaps in some communities, we need to have um, practitioners beyond physicians out, and one of their tasks is using the data available to them to outreach to communities and provide vaccination as well as other services that increase and improve health and well-being. Um, Community health workers. Maybe everything shouldn't fall on our healthcare providers who are already pressed. Perhaps we use community health workers to educate members of the community on vaccine safety and resources so that when they see their providers, they're primed and they are informed and are perhaps more ready to make a decision about vaccination. Employment and income, health insurance, insurance type matter in urban and rural areas. So increased access to health insurance, standards for health insurance coverage of adult vaccines, or universal coverage of all recommended vaccines might be solutions. The types of policy solutions that I talked about when I covered the World Health Organization slide that are worth our consideration. Even if it's not universal health care, universal coverage of vaccines could move us forward. Um, Older patients, one of the reasons for suggesting this is that studies have shown that older patients who know that Medicare covers the cost are more likely to be vaccinated. than people who do not, who have Medicare but are not aware that Medicare covers those costs and that they can do this without an additional cost. One of the tools that I'm going to recommend is the use of the enhanced culturally and linguistically appropriate standards, the class standards. This is a set of standards that we've had the class standards for a long time, and most of the providers in the audience will recognize the class standards. But I am saying this because a lot of times people link the current enhanced class standards to the original class standards that focus a lot on communication issues. The enhanced class standards focus on systemic issues for producing equitable distribution of health resources. And there are 15 standards that instruct not just individual providers, but organizations on how to maintain culturally and linguistically appropriate services, but also how to advance health equity, improve quality, and eliminate disparities in healthcare. They start with the principal standard, which you should be able to see on your slide now, that talks about providing effective, equitable, understandable, and respectful quality care and services. The idea being that if you take this approach, the remaining 15 standards will support you in achieving that goal. And they're divided into 3 additional areas. The remaining standards are divided into 3 areas: governance, leadership, and workforce, communication and language assistance, and engagement, continuous improvement, and accountability. With governance and leadership, it's really important that the leaders in the health system and the public health system take responsibility for assuring that the resources that are needed to address the needs of vulnerable communities are there. They need to think about where are they directing their services, where are they providing their services, how are they addressing the needs of those with different different health insurance status? How are they addressing the needs of those who live in communities with few providers? What are their plans for assisting and or joining together to assure that the level of resources provided in those areas are commensurate with the need in those areas? And when we talk about communication and language assistance, it's important that we continue to focus on interpretation and translation of materials. That's essential to the provision of good care. It's surprising to me, but many in the audience will recognize we still have times when people who are not comfortable with English as their first language receive information on materials, including vaccines, that's in English, and then they're expected to understand, decipher, and make the best decision for their health and well-being using that information. We must do better, but we must also understand that under those standards, we're also talking about individuals who have lower levels of health literacy and literacy. And it's important for us to understand that we need to design materials, share materials that really allow people to understand the information regardless of their educational level, literacy level, and health literacy, and be patient and be willing to provide the support to answer the questions so that they can, and explain things so they can make the best decisions. The last set of standards address engagement, continuous improvement, and accountability. We need accountability systems so that providers, practices, large and small, and our health and healthcare systems are able to examine what have they done, how far have they gotten in addressing, making sure that every adult who is eligible or who needs recommended vaccinations have actually received information on those vaccinations, have received a recommendation, have had their questions fully answered to their satisfaction. We need to monitor our vaccination rates and understand the factors that seem to be driving improvements or stagnation in those rates, and have people assigned to develop plans to help to try to address the factors that we see influencing vaccination rates in our communities. We need the capacity, and we need to be thinking about not just looking at the state as a whole or the county as a whole, but disaggregating data so that we can meet the needs of those who are most vulnerable and most in need. And with that, I'm going to stop. Thank you for listening today, and I'm happy to respond to questions.